Okay, so good day everyone. So we are going to discuss chapter 12. So this is one of our body fluids, which is our synovial fluid. Okay, so before that, I'm going to show you a video regarding an illness related to our synovial fluid. So this is a video explaining what is rheumatoid arthritis.
Bones provide support for the body and aid in its movement. The place where two or more bones meet is called a joint. Joints may be immovable, slightly movable, or freely movable. A synovial membrane surrounds movable joints. Inside the membrane, synovial fluid lubricates and nourishes joint tissue, such as cartilage. Articular cartilage is a tough, slippery covering on the ends of the bones, which allows smooth joint movement. Joints give the body flexibility, precision of movement, and help in supporting the body's weight. Arthritis is any disorder that affects joints. It can cause pain and inflammation. Rheumatoid arthritis is the second most common type of arthritis. The joints most commonly affected are in the wrists, hands, knees, ankles, and feet. It typically occurs at the same joint on both sides of the body. It can also affect other organs in the body, such as the eyes, skin, heart, lungs, kidneys, nervous system, and digestive tract. Rheumatoid arthritis is an autoimmune disorder. This means the body attacks itself by mistake. In rheumatoid arthritis, the immune system attacks joint and organ tissues. Here's how it happens. The white blood cells of the immune system move into the joint. They release chemicals called cytokines, which attack the cells of the synovial membrane. These chemicals cause synovial cells to release other destructive substances. They also cause the synovial membrane to grow new blood vessels and form a thickened area called a pannus. Over time, as the pannus grows, it invades and destroys areas of cartilage and bone inside the joint. Inflammation causes fluid buildup in the joint, making the joint swell. Eventually, without treatment, the joint space narrows and ankylosis can occur. Ankylosis is fusion or growing together of bones in the joint. This results in the loss of the ability to move the joint. There is no cure for rheumatoid arthritis. However, doctors commonly prescribe various combinations of the following medications that, when taken together, can reduce inflammation and pain and slow down joint damage. These include non-steroidal anti-inflammatory drugs, or NSAIDs, steroids, and standard disease-modifying anti-rheumatic drugs, or DMARDs. If standard DMARDs aren't working, doctors may prescribe newer drugs called biologics, also known as biologic DMARDs. Physical and occupational therapy, along with low-impact exercise, can increase muscle strength and help keep joints limber. For severe rheumatoid arthritis that has not been helped by other treatments, a doctor may recommend a surgical procedure. For example, a joint replacement procedure, also known as an arthroplasty, may be recommended. For joints that are difficult to replace, joint fusion, also known as arthrodesis, may be recommended. During this procedure, the joint is removed and the bones are fused together with bone graft. Another surgical procedure for severe rheumatoid arthritis is a synovectomy. During this procedure, the synovial membrane surrounding the joint is removed. In some cases, an arthritic joint may need to be replaced with an artificial joint. For more information, talk to a healthcare provider.
Okay, so as you have noticed, the video is all about rheumatoid arthritis. So it has something to do or in relation to our topic today, which is synovial fluid. Rheumatoid arthritis happens in the joints, and synovial fluid happens to be the one that lubricates and cushions our joints. Now, for our learning objectives, we need to describe the formation and function of our synovial fluid, state the 5 diagnostic tests performed most routinely on synovial fluid, describe the appearance of synovial fluid in normal and abnormal states, discuss the normal and abnormal cellular composition of synovial fluid, explain the differentiation of monosodium urate and calcium pyrophosphate crystals used in polarized and compensated polarized light. State the clinical significance of glucose and lactate tests on synovial fluid. And lastly, describe the relationship of serological testing, and joint disorders. Okay, so first we need to identify or define what is synovial fluid. So other books may call it joint fluid. So it is a viscous liquid in the synovial joints. So the function of synovial fluid is first, it lubricates joints and reduces friction, as in case of all joints in the body. Okay. Also, it provides nutrients and absorbs shock, okay, in cases of trauma, okay, or accidents. Okay, most of them or mostly happens with people with active lifestyle like athletes, to. So they also provides nutrients and absorbs shocks. Type A synoviocytes, which are the phagocytosis, and type B synoviocytes are the one that produces the hyaluronic acid and collagen. So they formed as a plasma ultrafiltrate with added hyaluronic acid. So again, uh, there are two types of cells. Okay, or two types of synovial cells, also known as synoviocytes. The first are the one that protects our our synovial fluid. Okay, they are a form of phagocytes, and there are also type B. Okay, synoviocytes, which are the one that produces hyaluronic acid and collagen. So synoviocytes are the one that releases our synovial fluid in the joints. Okay, joints or synovial fluid or ultrafiltrate of our plasma, like all other body fluids. Okay, only that this body fluid is unique because of the presence of hyaluronic acid and collagen, okay, which are produced by our type B synoviocytes. So in cases of infection or in cases of abnormal pain, okay, caused by infection in the joints, sometimes we often collect samples of our synovial fluid in order for us to determine what is the cause of the infection or what is the cause of the joint pain. Okay? The collection of our synovial fluid is called arthrocentesis. Okay? So it is a joint aspiration via a fine needle, so collected via arthrocentesis. Okay? Okay, so normally our joint fluid or our synovial fluid is less than 3.5 ml. Okay? Again, this is the average normal volume of our synovial fluid. Okay, in the knee, particularly in the knee. But in cases of inflammation or infection, the volume of our knee fluid or the synovial fluid in our knees may reach up to 25 ml, okay, 25 ml during inflammation. So again, the inflammation of our knee is signifying that there is an underlying cause, probably caused by a fungal or bacterial infection. Okay? So, we are preparing 3 tubes, no, to test for different sections in the laboratory, or 3 tubes for the different areas in the lab, or different types of tests in the laboratory. For tube 1, okay, which is our red top tube, used to test for chemistry. Okay, clinical chemistry test. Particularly, we have the glucose and protein, and also uric acid. For test tube 2, we are using the EDTA or the lavender top, or may use heparin or the green top. This is for our cell count or differential count, and also for the microscopic identification of our crystals. And lastly, we have our sterile cup, no, for our microbio, or the gold top for our microbio testing. We should also avoid anticoagulants which are powdered in form, because it may interfere with our uh, microscopy with crystals, since it mimics the appearance of crystals in the microscope. Okay, and right after collection, these tests uh, should be done immediately. Okay, so I'm going to show you a video of an actual uh, arthrocentesis method performed in the knee of a patient. Okay.
In this video, we will review how to perform a knee arthrocentesis. These are the essential elements needed to perform a knee arthrocentesis. Always obtain consent with your patient prior to this procedure. To position the patient, have them flex their knee about 15 degrees with a towel roll underneath. The suprapatellar pouch can be accessed posterior to the patella, either on the lateral or medial sides. Prepare the knee with chlorhexidine or iodine and apply the sterile drape with exposure to the superior portion of the knee. Draw up 1% lidocaine and make a skin wheel, and then infiltrate the intended tract, posterior to the patella and at the top 1/3 portion of it. You are aiming for the intercondylar notch, which is deep and slightly inferior to your entrance point. Attach your 18 gauge by 1.5 needle to a 20 cc syringe and go along your tract. Aspirate as you enter the skin. If you hit bone, withdraw to the skin and redirect. Once you have entered the suprapatellar pouch, continue aspirating while milking the contralateral portion of the knee. If you are instilling anesthetic and/or steroid, then replace your syringe and injection.
After removing the syringe with your knee aspirate, you may inject your anesthetic and/or steroid via a new syringe. Send the knee aspirate for analysis after putting a cap on it.
Okay, so you have witnessed the method of arthrosynthesis, or what we call the aspiration of our joint fluid or synovial fluid. So this method is done first. No, the first reason for doing arthrosynthesis is to collect sample for testing. Okay. Secondly, arthrosynthesis is done in patients with inflamed joints or knee joints to alleviate the pain, because removing the excess amount of fluid makes the inflammation subside and the pain to somehow uh, lower, okay, or somehow it makes the it makes the pain uh, somehow lighter. Okay. Now let's go on to the examination of our synovial fluid. So, like other body fluids, laboratory testing for body fluids is still divided into these types of testing. So first, we need to discuss the physical, the chemical, and the microscopic examination. In this type of body fluids, we added microbio or bacteriological testing of synovial fluid. So first, we have physical examination. So under physical examination, we discuss the color, the clarity, viscosity of our synovial fluid. So under normal condition, our synovial fluid is colorless. Colorless to pale yellow. This is the normal color of our synovial fluid. Okay? If our patient, or if the patient's knee or joint is inflamed, okay, probably the synovial fluid that would be extracted from the patient is yellow. In cases of patients having an infection, their synovial fluid would probably be in a greenish tinge. Okay, and lastly, if the synovial fluid or our joints, no, is bleeding, okay, in the form of hemorrhage, the synovial fluid that would be extracted from the patient would be in the color red. Okay, for clarity, for clarity, uh, the turbidity of synovial fluid would be uh, in relation to the WBCs, or white blood cells, crystals, and debris found on our synovial fluid. Okay. For viscosity, okay, the normal viscosity of our synovial fluid would be 4 to 6 centimeters string test. This would account for a lower, or this would account or lower in cases of arthritis. It means that less viscous, the lesser viscous our synovial fluid, okay, it may indicate arthritis. Okay, mucin clot test is a test that determines the clotting formation of our synovial fluid. Okay, if in mucin clot test, our synovial fluid turns into solid, it is a good indication of a healthy synovial fluid. And if there is no clot, probably, okay, the synovial fluid is it is an indication of a poor synovial fluid testing. Okay, so we are now on the microscopic part of testing. So here, we're going to determine the different types of cells, identify and count, okay, the different types of cells that may be present in the synovial fluid. Okay, so normally the WBC count would be less than 200 count per UL. Okay, and it may reach up to 100 more than 100,000 in patients with infection. So in this method, we are only using saline as diluent, okay, and avoid acetic acid as it may kill our WBC. In differential counting, normally we account for neutrophils of less than 25%, lymphocyte less than 15%, okay. Increased number of neutrophils would account for a septic or bacterial infection. Increased number of lymphocytes, probably it is a non-septic or a viral infection with our synovial fluid. Okay? Abnormal cells can be also be found like the RA cells, Reiter cells, the LE cells, and hemosiderin and lipids. Okay, so again, we are now on our crystal identification. Okay, so this is one of the tests used or one of the tests performed with synovial fluid. Okay, because some of these crystals may cause gout, no, in patients accumulate in their joints. So we can test our crystals or examine our synovial fluid in a fresh sample and stained wet mount under polarized light microscopy. So there are several types of crystals that may be uh, found on our synovial fluid. But we are going to focus on these two types of crystals since these are the ones that causes gout and pseudo gout on our patients. So monosodium urates is the one or the causative or the cause of our gout. So it is a needle shape, yellow with negative bifringens, and our calcium pyrophosphate dihydrate is the one that causes our pseudo gout. Its shape is rhomboid, color blue, and with positive bifringens. So there are other types of crystals which are cholesterol, calcium oxalate, okay, which are less of a common and less of pathologic compared to these two types of crystals. Okay? So ito yon. These are the appearance of our crystals under microscopy. So the monosodium urates, which is the cause of our gout. Okay, so these are needle shape, no needle shape with negative bifringens. Okay, this is the calcium pyrophosphate dihydrate. Okay, also cause of pseudo gout. So the shape is rhomboid. Okay, and I think the color is blue with positive bifringens. Okay, so we are now on our chemical test. Okay, performed with our synovial fluid. Okay, so normally the glucose level of synovial fluid is less than or equal to 10 milligrams per dl below plasma. So lower in infection or in patients with inflammation. The protein in our synovial fluid is less than 3 grams per deciliter, higher in patients with inflammation and hemorrhage. For our uric acid, it is increased in patients with gout. Okay. For lactate, more than 9 millimoles per liter and in patients with septic arthritis. Okay? For our enzymes, we have LDH, okay, phosphatases, which are also rheumatoid arthritis severity indicators. So these enzymes helps us to determine how severe is the cases of patients having rheumatoid arthritis. Okay? For our microbiological tests, so these tests are performed in our bacteriological lab. Okay, so our synovial fluid is smeared on slides performed with gram stain, okay, stain with our gram stain, and culture for all samples, so GSCS. So the common types of bacteria, okay, found in our synovial fluid is Staphylococcus, Streptococcus, Haemophilus, and Neisseria gonorrhoeae. So we are using the chocolate agar plus enrichment media. We can also use PCR for Borrelia burgdorferi, okay, the one that causes our Lyme disease. And test for Mycobacterium tuberculosis, yung our fastidious bacteria, which can be tested using our which can be tested using our acid-fast staining procedure. Okay. Okay. So we are now on the serological test performed with synovial fluid. So serological testing is very important to detect autoantibodies, no, like our rheumatoid arthritis and systemic lupus erythematosus, which also affects our joints and our synovial fluid. Okay, Lyme arthritis caused by Borrelia burgdorferi, no, we can use PCR to test, and also we can use serological test to test the antibodies. Okay, synovial fluid testing confirms serum findings with these types of illnesses. Okay, so I'm going to show you a video of how rheumatoid arthritis and systemic lupus erythematosus may be similar and differ in some and most of ways.
You wake up stiff and your joints ache. You're exhausted and you don't know why. Your doctor suspects it's lupus or rheumatoid arthritis. But which one is it, and what if you get the wrong diagnosis? Vanessa was in this exact same situation. First, she was told that she has lupus, and it was based on a positive antibody test, a positive blood test. But months later, her symptoms told a different story. It was rheumatoid arthritis all along, and by the time she did get the right diagnosis, there was already damage to her joints. If you've been told that you have lupus or rheumatoid arthritis, I'll tell you exactly how doctors tell the difference, what key symptoms to look for, and why your diagnosis may change over time. And a quick trick to try to figure out what type of arthritis you might have just by how well you can flatten out your hand. Hi, I'm Dr. B, a rheumatologist and lifestyle medicine specialist. I've treated thousands of people with autoimmune disease over the years. So what's the reason that lupus and rheumatoid arthritis get mixed up with each other? Well, first of all, they can look pretty similar. They both can have joint pain and swelling. They can both have fatigue, as well as morning stiffness, which is that stiff feeling in your joints when you get up in the morning. And they can actually both be associated with the same blood test positivity. For example, the ANA test, which is the anti-nuclear antibody test. Yes, it's supposed to be positive in lupus, but we often see it positive in rheumatoid arthritis as well, which kind of puts people on the wrong track and potentially the wrong diagnosis. Because about 30% of healthy people can have a positive ANA test. And it's also seen in so many different autoimmune diseases, which is part of the reason there was this confusion with Vanessa. Okay, so let's talk about some key differences. Clues for lupus. Usually it affects more than the joints. It can affect the skin, the kidneys, the heart, the brain, so many different areas. You can get rashes. The butterfly rash that a lot of people know about can happen, or even sun sensitivity when you go out in the sunshine, and you can get rashes, but also you can get this severe fatigue when you're out there. Now, a lot of people can look flushed when they're out in the sun, but this is a different sensation. You can even get a thickened rash on your face, but oftentimes the effects of the sun can last from hours to days. Blood tests could show that positive ANA antibody, but also different cell lines could be abnormal, such as the white count could be potentially a little bit low. The platelets could be involved. You could have some anemia or even kidney involvement. Symptoms can flare and disappear unpredictably without any rhyme or reason. You could be perfectly fine one day and feel extremely fatigued and tired the next because you're having a flare. Rheumatoid arthritis clues are a little bit different. Rheumatoid arthritis mostly affects the joints and it's symmetrical. If you have swelling on one wrist, oftentimes you might have a little bit on the other wrist. May not be the same amount, but it tends overall to be symmetrical. If it's in the fingers on these, maybe it's on the last two over here, maybe not the exact same ones, but still it's more symmetrical. I've even seen people get injured on one side with some swelling because of an injury, and then they get it on the other side because of the rheumatoid arthritis. You can get a rash with rheumatoid arthritis. It's a vasculitis, but honestly, it's not that common anymore. It's fairly rare. I've been a rheumatologist for over a decade, and when I was first in training, we certainly saw much more of this, but over the years, with all of the new medications that are out, we don't see the rashes as much. Although there are other organs that could be involved, such as the eyes, you can get scleritis, inflammation in the eyes or in the voice box, but mainly it's a joint condition, and you can really see some joint damage over time, especially if the inflammation is not taken care of. Blood tests could be something like a rheumatoid factor or a CCP antibody, which can also be positive. Although sometimes we're not lucky and they're negative, and you get something like a diagnosis of seronegative rheumatoid arthritis, which is also rheumatoid arthritis, but it just means that those blood tests weren't positive. It can be a little harder to pick up because of the fact that you don't have this very easy checkmark blood test to tell you what you have. Vanessa didn't have the rashes or the kidney damage or the sun sensitivity that you often see in lupus. What she did have was pain in her joints. And when I met her, I was looking at the joints, at how they looked. So when you took her hands, they were deviated. But when I tried to move them back, they didn't really go back very much. And that's important, right? Because in some people, if you go like this, it does kind of go back to normal. And in others, if it's deviated, it'll stay like this. Also, I put her hand on the surface and I tried to flatten it, and it would not flatten out. In lupus, usually you can kind of push the joints back for the most part. But in rheumatoid arthritis, especially if you have erosive disease, you're not able to. So this is an important clue. Getting back to Vanessa, she had joint pain. It was in her hands, it was in her wrists, it was in her elbows, and it was mostly symmetrical. So it was a little confusing with that ANA blood test, the features that she had of this young woman of reproductive age who now had joint pain, joint swelling, and she did have some stiffness in her joints. But then when I met her, we do the whole workup again, and I had checked for x-rays. And in those x-rays, she had erosions in her joints. Erosions are permanent bone damage inside of your joints. Think of a smooth road that you're going down that suddenly develops potholes, these little areas that you definitely don't want in that road. And once that damage happens, it's hard to reverse. In RA, the immune system attacks the lining of the joints, causing irreversible damage if you don't treat it. So this is a very key difference between lupus and rheumatoid arthritis. Usually in lupus, yes, you can have joint pain, you can have joint swelling, but you don't usually have erosions, this permanent damage. But in rheumatoid arthritis, you can certainly have that. And it is irreversible, which is always what we're trying to kind of fight against. So when people say, I can handle the pain, I can handle the stiffness, I can handle the swelling, but the problem is once you get this irreversible damage to your bones, we can't do anything about that. And it may not bother you now, but it could be a really big problem for you in the future. Seeing these erosions on Vanessa's x-rays, I checked her blood tests again. And to be honest, even if they were negative for anything, I can see that she has permanent damage and needs to be treated accordingly. But in her case, actually her CCP antibodies had now become positive, definitely leaning more towards a diagnosis of rheumatoid arthritis. So let's talk about why your diagnosis might change. This is something I think everyone who has an autoimmune disease should know. If you've ever been to a rheumatologist or have discussed any rheumatic condition, you can see that there's a lot of vagueness in this field. Because while we love checking blood markers, they're not always positive. They may become positive later on, or they may be leading us on a wild goose chase. As I had pointed out before, an ANA test, which a lot of people come to see us for, is positive 30% of the time in a healthy population. So it doesn't mean that you have autoimmune disease, but it does mean that you should maybe look for one, or at least see if there are any other symptoms that are related. Oftentimes people may come in for an ANA and wonder if they have lupus, and we end up diagnosing them with a completely different condition because it was like a red herring for the case. And yet there was other things going on because there's so many other conditions that are associated with it besides lupus. Sometimes when you have rheumatoid arthritis, the antibodies, the blood markers may not be positive initially, but it's not that you should be checking them every few months because it probably won't make a difference. But if you check them at baseline when symptoms start, and maybe if you check again a year and a half later, you may discover that there's a change change in the antibody status and it's now positive. But even if it's not, really what you have to treat is symptoms and organs. We don't want damage to the organs. So we go ahead and treat sometimes. And it's fine to do that, and it's also fine to pull back when we think that this may not be the right diagnosis, because such is the world of autoimmune disease. A diagnosis isn't always final, blood tests aren't always exact, which is why it's so important to reassess symptoms over time. As long as you're always thinking, is this correct? Am I being appropriately treated? Am I feeling better? Then you'll go much further. Getting back to Vanessa for a second, can you have both rheumatoid arthritis and lupus? Actually, you can, but it is pretty rare. I would say even in our clinic, we don't have too many people that have that shared diagnosis. And those people have features of both, but most people will have one or the other. So oftentimes when you see a rheumatologist, they want all these follow-up appointments, and this is one of the reasons for it, because symptoms can change. Your pain can worsen. New symptoms can happen. And if the treatment isn't working, it's time to reassess. So if you're struggling with symptoms and you think you could have lupus or rheumatoid arthritis, here's what you should do. First, make an appointment to see your doctor. Usually, most people start with primary care and they can check the blood test and they can kind of see if the patterns may fit into place. Number two, track your symptoms, because these are all the questions a rheumatologist will ask. What time of day is it worse? Do you have stiffness associated with it? Do medications help it feel better? Does exercise help it feel better? What makes it worse? Ask for the right test for autoimmune disease, especially if you have a strong family history or anything else that could clue you in, like the symptoms that we talked about. Vanessa eventually did get the right diagnosis and started treatment for her rheumatoid arthritis and did much, much better. But if she had waited longer, it would have led to permanent disability, because she's clearly in that boat where she is getting erosions. Not everybody gets that permanent damage, but some people do. So she definitely needed more aggressive treatment. Now I want to hear from you. Were you ever tested for lupus or rheumatoid arthritis? Was there ever a question of the correct diagnosis? What was your experience like? Drop a comment. And if this video helped you, share it with someone else you think that could also benefit. I'm Dr. B from Plant Forward MD. I'll see you next time for more tips on your health. You wake up stiff and you're
Okay. So we are now on the end part of our topic, no? So if you have heard the video, there are cases wherein rheumatoid arthritis can progress into systemic lupus erythematosus. So patient having both is a rare condition. So they may share similar diagnosis, similar treatment, similar symptoms, but sometimes one is uh, superior to another, no? So they have different uh, medication regimen. So that's why it is very important to diagnose properly and to so that we can give the proper treatment for the patient. No, so to summarize it all, so there are different types of parameters to identify if synovial fluid is normal or abnormal. So we have color, okay? We have color, clear to pale yellow, no? Uh, Also our clarity. So we have turbid, cloudy. Also our sometimes our the color may signifies what type of condition our synovial fluid is up to. So if it's red, probably there's hemorrhage. Okay. If it's green, it probably may have infection. Okay. Or yellow, inflammation. Okay. So viscosity, normally we have high viscosity. Our synovial fluid have a higher viscosity. Okay? Lower viscosity or less viscous synovial fluid may indicate arthritis or joint pain. Okay? For WBC, less than 200 per UL, okay, is normal. More than 2,000 per UL is an indication of inflammation. More than 50,000 per UL is an indication of a septic or a bacterial infection. Okay? For glucose and plasma, okay, uh, for glucose, okay, and glucose plasma, lower glucose than our plasma may indicate infection. For our protein, less than 3 grams per deciliter may indicate inflammation. Okay? For crystals, we have again monosodium urates for our gout, the cause for gout, and CPPD or the calcium pyrophosphate dihydrate, that is the cause of our pseudo gout. Okay? So thank you everyone, and that's all for our synovial fluid. Thank you.